Hi, everybody. November is National Hospice and Palliative Care Month, and today we're talking to Jessica Whittemore, who is a social worker with the Chesapeake Supportive Care practice, which is part of Hospice of the Chesapeake. So I want to say welcome, Jessica. Thanks for Zooming today and coming in to talk about the role of a social worker.
Thanks for having me today. I'm excited.
Awesome. So before we jump into what a social worker does, let's give a quick rundown of supportive care, which is also called palliative care. And let's start with that. Like, there are two words describing one thing. Can you talk a little bit? Is it the same thing or is it different?
Sure. So I'm the social worker for Chesapeake Supportive Care. That's the name of our company under Hospice of the Chesapeake. And supportive care really is there as an extra support. That's why we call it supportive care. I guess palliative care is probably, when you say what's the difference between the words, palliative care is the more medical term for it, right? Palliative medicine is a medicine specialty, just like you would see an oncologist or a cardiologist, pulmonologist. Palliative practitioners are just another medicine specialty. And our medicine specialty is chronic life-limiting illnesses, right? So we meet with patients who have any type of chronic or life-limiting illness diagnosis. Our goal in palliative care, what we focus on, is symptom management and goals of care discussions. So we're really looking at the whole person and how all these different parts interject and work together, and how we can make you have the best quality of life possible while you're seeking aggressive treatments and while you're living with this chronic illness.
So let's talk about, just give me a few examples of either what would life-limiting illness or a chronic illness be.
Sure. Gosh, there's so many, and I feel like I learn new ones every day.
Yeah.
But cancer is probably one of the first ones that people think of. But we also see patients with chronic heart failure, CHF, congestive heart failure, CHF, COPD. We have people with Parkinson's, dementia, Alzheimer's. I've seen patients with muscular dystrophy, cerebral palsy, just all sorts of, there's, unfortunately, sadly, there's different illnesses every day.
Right. And I think too that some people might not be aware of, as people age, you kind of accumulate more conditions. As we're living longer, there become, additional things that pile on top of each other. So let's say you may have a patient. Say that again. Say, what's that phrase? What's it called again?
Comorbidities.
Comorbidities. There we go.
So when you have diabetes on your own, you're kind of okay. But then if you have diabetes, then you have some heart trouble, and you have some kidney trouble, that becomes a chronic issue because all these parts of your body are interacting with one another. There's so many moving parts of our body, and sadly things can be affected or go wrong with any of them. So you're right. Yeah. The older we get, the longer we live, the more that can go wrong with
it becomes more complicated. And I think that's sometimes a piece that people aren't really clear about, how supportive care can kind of be the connecting piece for that. And I'm thinking that's really where your role comes into play too, as far as looking at the bigger picture instead of each isolated condition. Mm-hmm. The goal is to look at it all put together.
Yeah, absolutely. Like I said, the goal is to look at the whole person. When you see your oncologist, they're just looking at your cancer. If you see a pulmonologist, they're just looking at your lungs. If you see a cardiologist, they're just looking at your heart. Every doctor is looking at something specific. Supportive care, I always call us like the puzzle makers. We are here to put all those pieces together and see how it's affecting you as a whole person, right? When we talk a lot about quality of life, we can't look at your quality of life unless we're looking at all those moving parts,
right?
Because they all affect each other.
Right. And if you think about, like, let's look at, you've mentioned oncologists and pulmonologists and cardiologists, all those specialties don't have a social worker component
They
as
don't. They
part of their
don't.
practice. So let's dive in there. What sort of big picture, what do you bring to the table for supportive care? What's your position? What's your
So
role?
the coolest part of supportive care is that we are an interdisciplinary practice, right? We're not just sending a nurse practitioner to see you. We're not just sending our doctor to see you and then just kind of moving on. Like I said, we're focusing on the whole person. And to do that, you have to look at, all of the psychosocial, emotional things going on as well as spiritual care. We also have a chaplain on our team. We really try and look at everything, because our social, emotional, psychosocial, emotional all affects our health, and our health also affects our psychosocial, emotional. It's a cycle, and they all work together. And unless you're addressing all the issues, you're really only addressing part of it. So as the social worker on the team, I meet with patients. I do psychosocial assessments just to see where they're at. I do crisis intervention. I do resource connection. I do a lot of therapy with our patients. Living with a chronic or life-limiting illness is not easy, and there's a lot of things that come up. Supportive care, like I said, focuses on that quality of life, and I am a firm believer that you can't just focus on medical things if you're looking at the quality of life. It's the bigger picture, and that's where social work really comes in. I'm here to help you figure out how to live the best you can with this illness, whether it's emotional help you need, spiritual help you need, resources in your community you need. And that changes over time, right? When we first get diagnosed with an illness, and that's when palliative care, supportive care, that's when that referral should happen, right? As soon as you tell a patient they have this chronic illness, a referral should come to us to help navigate it, because it's a long journey. There's a lot of ups and downs. And so in the beginning,
I'm going to stop you a second. If someone who, the patient themselves is interested in having this type of appointment, do they need to ask their physician for a referral? Okay.
Yes. We only see patients when we have a physician referral.
Okay, but that could be from the primary care provider or their specialist.
It can be from any specialist or your primary care provider. I always encourage people, if you think this program is right for you, talk to your doctor about it. Talk to who's been treating you and say, I think I would benefit from this program, and see what they say. And because living with a chronic life-limiting illness is hard. And when you first get diagnosed, I would say the biggest thing we do is talk a lot about disease progression and trajectory. People have a lot of questions, right? You hear all these scary words. What do they mean? You go to your doctor and you're in there for 15 minutes and they say, you have COPD, start with this inhaler, bye. And you don't know what all that means, how it's affecting everything. Supportive care is really good about, I would say we spend about an hour or more with our patients. Rarely are we in a visit for less than an hour. And we're really going over everything, answering those questions. There's no silly question. If you have a question about your illness, ask it. If we don't know, we'll figure it out or we'll troubleshoot it together. But it's a lot. There's a lot of questions, a lot of unknown, a lot of fear.
Right. And I'm just thinking too, from a social work perspective, you're going to ask different questions than a physician or a medical, nurse practitioner. Everybody has different lenses and different trainings and different. So
we really do. And I joke with my patients all the time about that. I'm like, listen, I know you talked about your bowel movements with your nurse practitioner. I don't care. I want to hear, XYZ. I want to know, how's your relationship with your daughter been? Is it still stressful? Is it better? How are you paying your bills? How are you getting your prescriptions? Have you been able to go to church? Have you been able to leave your house? Because all of those things really, interact with our pain. You know, like I said, we focus on symptom management and goals of care discussions. And pain is the number one symptom we see, right? That people are in a lot of pain. And I don't think you can look at pain and just prescribe something for it and move on. I think you need to look at underlying things that are causing the pain, and things that the pain causes, right? Like I said, it's tough living with a chronic illness. And that can lead to some depression, some anxiety, all sorts of things. And if you're not addressing those key elements as well, I think you're doing a disservice to your people.
Right. Yeah, definitely. And from what you're saying, putting those pieces together for the bigger picture. Like, let's talk a little bit about a situation or an experience that you've had, knowing with HIPAA and, all that kind of privacy, just something that's really kind of stuck with you from your experience as a social worker in supportive care. Is there somebody's journey that's really kind of impacted you?
There's been so many journeys I've only worked here for, 2.5 years now. It feels like just yesterday, but I feel like I meet someone every day that really inspires me. I learn from almost every patient. I learn about more resources out there. I learn about what they're going through. This job is so great. I will say one of the biggest things I've learned on this job and from our patients is that you really need to start where the patient's at, right? So we're all at different points in our life. We all have different resources, and all of our patients are at different points in their illnesses and their journey. For example, I have one patient who and I guess this should have started in the beginning when I told what supportive care was. This is an important point. We meet patients where they are, right? So we do have an office you can come to here on campus. Some people love our office, love coming to it, but some people can't leave their homes. So the majority of our visits are done in patients' homes. And home is defined as, your residential home, your apartments, your condos, what have you, but also assisted livings, nursing homes, really anywhere. And so when I go out to see patients, I'm usually in the field. And we had a patient who could not have us in their home, didn't really have a home, was transitional. And we met at an outdoor restaurant in the middle of the pandemic. And, I think that is really key in determining you have to start where the patient's at, right?
Right. And meet that. Yep.
Yeah, we're not going to be able to treat your symptoms medically until we figure out some of these things, right?
Right.
So
the basic needs.
I'm here and I'm the social worker, and I was actually first contact with this patient because some of these social issues needed to be figured out. If you can't afford to buy food for yourself, we're going to get you connected to Meals on Wheels or the food banks. You're not going to be prioritizing an expensive medication when you have these basic needs that need to be met.
Right.
And so really social work wise, and I will say our nurse practitioners are really good about it too, is we have to meet our patients where they're at. And how can we improve upon that? And how can we help your situation? Again, looking at that quality of life, how can we get there? And I think that's the biggest takeaway about supportive care. We're here to meet you where you're at. We talk a lot about goals of care because we want to know what your goals are, and help you to meet those goals. And, we've just met patients over the years wherever they're at, whether it's a home, an assisted living, or a restaurant, because that's what we've got for now,
Right.
and
Right.
And we're willing to go to wherever you are and meet you where you're at, and help you the best we can. And that's why every team needs a social worker.
Yeah, that makes total sense. I want to clarify too, when you were saying on campus, the location that that people could go to is in Pasadena.
Yep,
and it's the Hussman Supportive Care Center that has its own building. And if people feel more comfortable wanting to go to, a traditional office, that that's an option. And then as well as telemedicine, which is a great.
Oh yeah, we do telehealth now too. I mean, again, it's meeting you where you're at. If the best way to see you is through a video chat, we'll do that. If it's you want to come to campus here at our Husband Center, and it's beautiful. It's a new center, and it's got offices. And I a lot of patients will want to start coming out there because again, we follow through the duration of the illness, and there's a lot of ups and downs. So sometimes it's good to get out of your house and come see us here. But if you're having a very bad day or your mobility is changed, we can transition to see at home instead.
Yeah.
Our goals, again, really to meet you where you are and how can we best help? That's the number one question for all palliative care providers. I think anyway, I don't know if it's like a legit thing, but I think that's our number one question. Mm-hmm. How can we best help? How can we make your life the best as possible while you're going through all this? And we're here to help you any way we can.
Yeah. I think that's a great point. One other piece that I feel like we should talk about, because it is part of the bigger plan, and especially as folks are sort of going throughout the journey with their illness, is that looking at the advanced care planning, advanced healthcare decisions, the MOLST form. What's your role in sort of those conversations?
Yeah, absolutely. So those are really hard conversations for a lot of people, but they're also really important to have. And when we go back to kind of the beginning of this discussion, when I said we focus on symptom management and goals of care discussions, our goals of care discussions really reflect your MOLST and your advanced directives. And those are two different forms, right? Advanced directives are kind of they serve two purposes. They're a general overview of what your wishes are. And they also name someone to be your healthcare decision maker if you cannot make decisions for yourself. So it's extremely important because it's really tough. You want to pick someone you trust to follow your wishes. I always tell people sometimes it's not always the person closest to us because those are emotional things. It's someone who can follow your wishes and someone you trust to do that. Mm-hmm. So that's advanced directive. The MOLST form's an actual physician order for life-sustaining treatment, and that covers so many topics. Would you want CPR if your heart were to stop? Would you want to be intubated, a tube placed down your throat? Would you want a feeding tube? Would you want to go back to the hospital? All sorts of things. And the MOLST form, you can change at any time. So as your illness changes, your goals might change. Right. So that's why we talk about it at almost every visit, or what are your continuing goals? How can we help you meet them? Because as your illness changes, so do your goals. And social work's role in all that is we are here to help facilitate those conversations. They're very hard conversations. A lot of people don't like thinking about them.
Yeah. Especially, I'm thinking family members. I mean, there could be, let's say adult children of older parents, and the parents are probably, the older generation might be comfortable thinking about it, but having that conversation with their loved ones, their family members, could be.
And it's a scary thing to talk about.
You don't want to think about your mortality.
You don't want to think about it. Everybody should have some advanced directives though at any age, because you never know what's going to happen. But I will say, and social work, one of our main roles in advanced directives, when you talk about adult children and their parents, a lot of times there's several children who have several different opinions, right?
Yeah.
So I do a lot of family meetings to just try and mediate about everybody's thoughts and feelings, because everybody's thoughts and feelings are valid, right? And we want to hear everybody's opinion on it and how they interplay with each other. But at the end of the day, it's the patient's choice. And it's important that we're in a neutral setting where you can hear what your mom or your dad really wants at the end of life and how we can help make that happen. And it also, I think, is a big relief for family members at some point, because now the weight of making those decisions is off of them.
Right. So you're not in crisis mode.
Not in crisis mode. Yes. And so having these conversations early on, especially with the onset of your illness, and seeing how it plays out, letting your family know what you want is, like you said, you're not in that crisis mode and having to guess at things.
Right.
It's all been talked about. And we're here to support you through all those ups and downs and those different decisions that have to be made. And like I said, sometimes those goals change and we talk about that. And so the social worker's roles in it, we can help complete those at any time. We can change them at any visit. Sometimes we'll have someone who makes a decision and says, you know, after thinking about it, can you come back next week so we can change it? Absolutely, absolutely. Family meetings are important, and communicating your wishes are very important. So we help facilitate those discussions and those meetings as well.
That's awesome. That's awesome. Thank you so much for talking to me and explaining the role, the important, I think we need to qualify the important role of a social worker in support.
Absolutely. I think supportive care only works when it's an interdisciplinary team, right? So palliative care is most effective when you have your nurse practitioners and your physicians, you've got your social worker, you've got your chaplain, and we all work really well together to meet, again, the whole person. We're looking at your physical status, your psychosocial, emotional status, your spiritual status, because only when we're looking at all of that can we really have the best quality of life.
That makes a lot of sense. Thank you.
Thanks for having me.
Yeah. I also want to make sure to thank the John and Kathy Belcher Institute for their generous support of the community education programs at Hospice of the Chesapeake. Thanks.